Okay, we're gonna continue our presentation. We'll talk about end-stage liver disease. Um, we have two prognostic scales that we use for end-stage liver disease. One of them is the Child-Pugh Turkish classification, and the other one is model for end-stage liver disease. Child-Pugh is the old one, developed in the mid 60s, and was basically developed for depicting the prognosis of portosystemic shunts, the big surgeries that we used to do in old days. Nowadays, we do the tips, which is, I mean, nobody's doing these ultra major surgeries anymore. I mean, we do mainly tips if we want to do the portosystemic shock. While the model for end-stage liver disease, or the MELD score, is used mainly for transplantation purposes. Okay, um, as you see, the one-year survival rates for Child-Pugh classification, A, B, and C, is around 180 and 45% respectively. While in the MELD scale, from 0 to 9, 10, 19, 10 to 29, and 30 to 39 is approximately 93 percent, 86%, 71%, and 37% respectively. So to make the story short, if you are compensated, if you have a compensated liver cirrhosis, you're probably going to live beyond 12 years. While if you have a decompensated liver cirrhosis, probably without a transplantation, you probably have less than 2 years. The trajectory of functional decline in patients with decompensated cirrhosis probably will be erratic and unpredictable. It's not like cancer, where you have slow decline and then a sudden drop. And thus, death might be a relatively sudden and unexpected. All right. This is basically the Child-Pugh criteria, and I'm sure all of you guys are aware of it. It includes 3 lab, which is basically bilirubin, the albumin, prothrombin time, and 2 clinical features like the encephalopathy and the ascites. And as you see, above class C is above 10, which is the severe form of liver disease. And this is basically the criteria for the encephalopathy in liver disease, West Haven criteria. I used to live in this place, by the way, West Haven. It's in Connecticut. Model of end-stage liver disease, or what we call the MELD scale. So what is the importance of it? Is mainly for liver transplantation prioritization, and number 2 is a short-term risk of death. So we talked about the tips, which is a very important procedure that you need to be aware of. The guys from interventional radiology do this work. Unfortunately, it can lead to encephalopathy itself, but we don't do this old classic portosystemic surgeries like old days anymore. These were a hell of a bloody surgeries, and most of the time patients did not survive. Okay, the MELD scale is basically before 2016 was only three labs: the INR, the bilirubin, and serum creatinine. Okay, uh, plus this constant. Nowadays they have added the sodium, and then they added also the albumin. So now the MELD scale is 5 labs. Okay, and this to add to its accuracy. Also, the MELD scale differs from a patient on dialysis versus a patient not on dialysis. This is a comparison between the MELD and the Child-Pugh, and it gives you the mortality, uh, you know, uh, the percentage or the 3 months mortality here. Sometimes I wonder, I mean, these two, they're not the same. I mean, they don't give you similar results. Just to let you know, um, the MELD depends mainly on labs, while the Child-Pugh has two, 3 labs and two clinical, predictors. So they're different, okay? And their utilization should be different as well. So I would say the Child-Pugh is more important for the oncologist who wants to, treat the patient, and if you're gonna do like systemic shunt and stuff like that. While the MELD is mainly for liver transplantation, and also for assessing death in a short period of time. Okay, we'll jump into, of course, all of these topics. I discussed them, separately, in my videos and stuff like that. So if you want to watch them on the YouTube channel, you can watch the end-stage liver disease, end-stage kidney disease, CHF, and so forth. And I elaborated more on these prognostication skills. But here I'm trying to wrap up uh, you know, uh, the whole thing for you, or the big picture, for prognostication. Then we'll talk about end-stage kidney disease, and again, the factors associated with poor prognosis are again the poor functional status and poor nutritional status, advanced age, low serum albumin less than 3.5 is associated with 50% 1 year mortality. And then we have a scale, which is not specific for kidney, but since we don't have a specific one for end stage kidney disease, I mean, there is one actually, but nobody's using it, okay? And that's why I didn't put it with the rest of the stuff. But if anybody asks you about the kidney, I'll tell them the Charlson Comorbidity Index, which actually encompasses a variety of diseases, not just end-stage kidney disease. If the Charlson Comorbidity Index is above 8, you have a 50% 1 year mortality. Okay, another phenomenon, all right, and I talk deeply about it in my lecture about end-stage kidney disease, is the presence of calciphylaxis. And this one is associated with 55 to 65% 1 year mortality. Calciphylaxis is a kind of a peripheral vascular disease, a very nasty kind of peripheral vascular disease that you see in patients with end-stage kidney disease. So this is the Charlson Comorbidity Index. I do believe it's underutilized, this index, and I think it's extremely important to be, utilized, because in fact, I mean, we don't have a patient that's coming to us with only one pattern of disease. It's usually a mix. I mean, you have a patient with advanced dementia and congestive heart failure, or dementia and end-stage renal disease. I mean, it's very difficult to find somebody that has only one disease. Okay, and that's why I love this index, and thus you have to really think about it more, and keep it in your mobile or whatever, just to review it when you need to. As you can see, with Charlson, they put a score for each disease. So let's say score 1 for MI, CHF, peripheral vascular disease, and so forth. Then 2 for hemiplegia, moderate or severe renal disease, 6 for metastatic solid tumor or AIDS, and 3 for liver disease, moderate or severe liver disease, and so forth. Also, age plays a role in this index. If you're above 40, you have to add 1, to this total that you're gonna, come out with. So a very useful index. Again, we said that a very high score above 8 is almost like 50% mortality rate, annual mortality rate of 50%. All right. Please, teach it to your residents, because this is really a very simple, straightforward, scale, and it doesn't need a lot of calculation, and it combines all diseases together. I mean, you can, if the patient have more than one disease, that's fine. You can put them together and you can come out with a scale here. Okay, hospital eligibility for end-stage kidney disease. Patient is not seeking dialysis or renal transplant. Number 2, creatinine clearance is less than 10 cc per minute. And number 3, serum creatinine is above 8. I want to say something. I had patients, during my career that did not want dialysis, despite their numbers were terrible. And I want to say something. These guys were functioning, well, despite these numbers. And I don't know, the explanation of this, but not everyone will be having these symptoms that you see in the textbooks, about end-stage kidney disease. So in this situation, I put these guys in the hospital. I mean, home hospice. Okay. Since they don't want dialysis. Now, if you get dialysis and you decide at one day you're gonna stop it, you have only 10 days left for you. Okay. And I want to say, in this situation, you have to admit the patient to the hospital or inpatient hospice, like the one we have in Ain Shamsi. All right. Why? Because within 10 days, this patient will be overloaded, will be having delirium, will be having all kind of symptomatology, dyspnea, pain, everything. You need to bring him to the hospital. He cannot survive. You cannot manage him at home. And you need to explain to the family that probably he has less than 2 weeks to live. Okay? So this is what I'm trying to say here. There's a huge distinction between a patient already on dialysis versus a patient did not pursue dialysis from the get-go. The one that did not pursue dialysis from the get-go, probably he can, live at home with home hospice and he'll be okay. Maybe as he gets worse at the end of life, maybe he will need to be admitted. But the one on dialysis and stops dialysis, this guy has less than 2 weeks. And you have to admit him immediately to the inpatient hospice. Okay, AIDS or HIV. HIV now in Europe and USA, as you know, is a chronic disease. It's not like, like it used to be. The prognostication of HIV depends on 5 factors: age, the CD4 count, the HIV RNA copies, the CDC disease stage, and you can Google CDC stage and disease stage for HIV. It will give you a calculator how to calculate the prognostication of these folks. And then the HIV transmission through injection drug use. So these are the 5 factors for HIV prognostication. And as you can see, this is the CD4. As the CD4 count drops down, which actually reflects your immunity, and the viral load goes up, this is where you start to get what we call AIDS. All right. ICU. Again, all of these guys, I have separate separate topics. You'll find them on my YouTube channel, so you can look them up. But here I'm wrapping the whole thing together here. So some of the widely used prognostic models is the Glasgow Coma Scale. I'm sure all of you guys are aware of it. Acute Physiologic and Chronic Health Evaluation, or the Apache score. The SAPS, Simplified Acute Physiology Score. Sequential Organ Failure Assessment Score. The Quick Sequential Organ Failure Assessment Score. Prevent Score. The Shock Index. I want to say that the Apache and the SAPS and the SOFA, okay, we use them more or less for research, okay, not for clinical use. So ordinarily, you're not gonna find like ICUs doing this Apache just for the sake of the clinical information. No, they use it for research. Utilize this information to improve their outcomes and stuff like that. The one we use in ICUs is like the Glasgow, of course, and the Quick Sequential Organ Failure Assessment, and the Prevent, I use it a lot, and also the Shock Index for patients with hypovolemic shock. I'm sure all of you guys are aware about the Glasgow Coma Scale. Remember, there's another thing called the Glasgow Prognostic Scale we talked about earlier, or the GPS. So we have the GCS and the GPS. Okay, don't confuse them together. As you can see here, the Apache, these are very kind of, a sophisticated tests here. I'm not, as I said, just kind of have an idea about the parameters they're using in these scales. You don't have to worry about, memorizing any of them. Usually they come already, like in the computer system, you just need to fill up the numbers and that's it. And then you have, the sequential, the SOFA, is also dependent on cardiovascular, central nervous system, respiratory system. I mean, more also another sophisticated, scale for sepsis. Okay. And then we use one that's much easier, which is the shortened form of the SOFA. And I think this is something that you can memorize here. the Q SOFA, which basically depends on the altered mental status, tachypnea, and hypotension. So if you're 0 to 1, probably this is not a high risk. 2 or 3, you have a poor outcome. Another one I use a lot in ICUs is the Provent, and this is super simple. Age, currently on vasopressors or not. I mean, I'm sure when you go to ICUs, all of these folks, you'll find them on Levophed. So you put one for that, one for age, and then one for platelet count less than 150, and then whether the patient on hemodialysis or not. Okay. By the way, guys, I wanna say this. When the patient is in hemodialysis, they have a poorer outcome. Okay, so always you'll find patients on hemodialysis, the outcome is worse. All right, and then you have here 1 year mortality, as you see, 15%, 100% of if you have a total score of 4, the 1 year mortality is basically 100%. So you can really and the Prevent, by the way, is the actually there's a lot of talk about it nowadays, and they made some modifications on. I gave you the one that's really the basic one, but nowadays they actually added other stuff. There's no point to talk about it at this point here, but it's an important scale, especially for guys working in ICU and mechanically ventilated. And then you have the shock index, all right? For people that, having hypovolemia, the normal shock index is less than 0.7, while the, above 1 is high. And basically, it's heart rate above, divided by systolic blood pressure. So it's pretty straightforward. All right, predicting death within 72 hours, or what we call the horizon effect. Horizon is, in Arabic, is ufuk. And this slide is so important for palliative physicians, okay? Because in this slide, they predicted at least 13 indicators, with high sensitivity, more than 95%, predicting death in the last 72 hours of life, including pulselessness, respiration with mandibular movement, urine output less than 100, Cheyenne-Stokes breathing, audible airway secretions, non-reactive pupils, decreased response to verbal or visual stimuli, inability to close eyelids, drooping of nasolabial fold, hyperextension of the neck, grunting of vocal cords, and upper GI bleed. So please, try to memorize these 13 indicators, all right, because this will help you out to predict whether the patient is dying, or have less than 72 hours or not. CPR. So I want to say that, we always been taught that CPR saves lives, okay? I want to say that this is for a healthy patient that had a car accident, for example, on the street, but for these advanced illness and sick patients, okay, CPR actually is a torture, all right? And they found that these folks are probably their survival is less than 5%. So that's why, you see me talk a lot about DNR and all that stuff in the meetings and the rounds. All right, because there's no point to do CPR in somebody with metastatic, cancer, solid tumor, for example, or advanced congestive heart failure. I mean, with an ejection fraction, let us say 20%. You're gonna hurt the patient more than you will, help him out. Anyway, they found that patients, if they were located in the ICU at the time of the arrest and they're taking vasopressors, the chance for discharge is only 9.3%. If they're not on vasopressors, 21%. The overall, 15%, 15.9% survival to hospital discharge. So this is for a guy, in the ICU, guys, not outside the ICU at home. This is somebody that's in the ICU. They have only a 15.9% chance to go home. Conveying prognosis. Conveying prognosis frankly and clearly, with empathy. Most important when you give the prognosis is what is the most important to them. So try to always, communicate effectively with the family or the patient. What concerns you the most? What would you like to know about your illness? Is there someone else need to be here? And also, when you give prognosis, always give a range. All right. I mean, you will hear this question a lot. Doctor, how long do I have? So always give him, a wide range, like hours to days, days to weeks, weeks to months. There are barriers for communication, and these are lack of time, fear of patient emotions, loss of hope, physician feeling uncomfortable, and uncertainty of prognosis. I have a very nice presentation. You'll find it in the YouTube channel called Breaking Bad News. I'm talking about this topic in detail. One of the most important protocols, there are more than one, but the one that you need to learn is the Spikes protocol. And this was developed by this guy, Robert Buckner. And this guy actually passed away. And he was an oncologist and a famous TV host. And he came out with this 6 steps, for communication, setting, perception, invitation, knowledge, empathetic response, and summary or wrapping up things at the end of the meeting. I'm not going to talk about all of them. I'm sure as a geriatrician, you know about them. But I want to say number one is the setting. I mean, I see guys, people doing these meetings like on the hallway, doing it here, there. I mean, you should do this meeting in a room, that's dedicated for this kind of, meetings. All right. Number two, perception. Before you give information to the patient about or the family about their disease, try to understand what they know about their disease. This will save you a lot of time. So start by asking, what do you guys know so far about your loved one disease record? Before you give them all the information that you know, you're going to waste a lot of time in your life. I see it a lot in the ICU, by the way. The ICU physicians are very energetic and they just jump into, giving all the information, without asking the family what they know about the patient. And at the end, you need to always summarize what you talk to the family about. This is one of the commonest mistakes I've seen in communication. You know, you give a lot of information, and then at the end, the patient doesn't remember what you talked about. So before they leave the room, summarize things, the main topics that you talked about. One, two, three, four. That's it. The prognostic paradox. So the prognostic paradox, the content should not be too little versus too much. The timing should not be too early versus too late. The nature should not be pessimistic versus optimistic. The science, we need to be accurate. That's why we use scales, right? We use scores, art. We need to be general. Give the big picture. Don't go into minor details that has nothing to do with the disease. I mean, explaining the serum sodium is like 127, for example. I mean, these guys don't want to hear that, right? They want to know whether the loved one is dying, he's gonna get better, he's gonna get worse. This is the art of giving prognostication. All right, we're gonna end this presentation with key learning points. Uh, Awareness of prognostic survival indicators helps clinicians in difficult decision making process and can lead to better communication with both patients and their families. Prognostication has only probabilistic value, and this should be taken into consideration when examining the possible course of each individual illness. Trajectories for non-cancer chronic disease make prognosis prediction for these diseases more complex than that of palliative phase of cancer. And that's why I always say, prognostication in cancer is the easiest one. When you do palliative care for non-cancer, you'll more than you guys are taking care of dementia patients right now, but it's much more difficult than cancer, by the way. All right, I think we're done with our presentation here. I'm gonna just stop the recording. If anybody has any question,